This week on the BackTable podcast.
It all comes down to fundamentals, and do you have fundamentals to scale? And my fundamentals were put into me in my training program. And so have I been able to scale that out, whether it was doing aortic endografts, TIPS, complex venous reconstructions, critical limb ischemia? It really comes down to fundamentals. And if you have sound fundamentals, you can scale out to just about anything in this space, which is awesome. I have a lane problem where vascular surgeons and other specialists don't have lane problems because nobody's calling them for an abscess. All the other commodities that come with the specialty, but it's a risk reward that comes with the specialty, and it's been a great ride.
Ladies and gentlemen, welcome to the BackTable podcast. If you're a new listener, welcome. For all of our regular listeners, welcome back and thank you for listening. You can find all previous episodes of the podcast on iTunes, Spotify, or our website, which is backtable.com. Very easy to remember. Subscribe to the show, leave us a review, or reach out to us on social media. Now, a quick word from our sponsor.
This podcast is brought to you by GE Healthcare's Interventional Allia platform, your trusted assistant for image-guided therapies. With Allia IGS-7, they've introduced a new member to the Interventional suite, present when and where you need it. With its mobile robotic gantry, Allia IGS-7 brings precise and predictable motion through its laser-guided positioning. This means free and versatile motion on the floor, eliminating the need for overhead rails and allowing for head-to-toe coverage without moving the table. To learn more, visit gehealthcare.com. Now, back to the episode.
Our topic today is cone beam CT. We have an older episode on this from November 2019 with Dr. Austin Bourgeois, the good Dr. Bourgeois. Episode 51, super helpful, but also 5 years old at this point. So to help refresh us and dive a little deeper into this topic, we have Dr. Michael Miller from Atrium Health, Wake Forest Baptist Hospital in North Carolina. Michael, welcome to the show.
Thanks, Chris. Happy to be here.
Instead of saying all that for Wake, can I just say, hey, you're awake? Like, is that how you guys refer to it?
I mean, traditionally, it's been Wake Forest Baptist Hospital as far as I've known it. But with all the consolidation of healthcare systems, here we have Atrium waiting to find out when we're going to be named advocate as a continued consolidation of healthcare systems. So not a dramatic impact on our practice, but I still walk around in Wake Forest gear, pretending.
All right, good. All right, so just icebreakers, will you tell us about your practice and a little bit about your training? So a little bit about training, a little bit about practice.
So I did my residency and my fellowship at Duke, finishing in 2000. Went to a small private practice in Latrobe, Pennsylvania, where I practiced until 2003. Then came back to Duke and was faculty there from 2003 till 2016. 2016, I got an invite to be the division director at Emory. So I went down and gave that a shot. And that lasted 2 years based upon the practice and family. You know, it just really came down to keeping the whole thing together. So in 2018, I made my way back to North Carolina and landed here at Wake Forest Baptist Hospital. Kevin Dickey actually brought me in at that time as a medical director. And since then, in 2021, actually became the division director. That's pretty much my journey at this point. I could talk about practice if you'd like.
Yeah, like to hear about the practice. But just to clear up, radiology residency, then the 1-year IR fellowship, and then now over at Wake. Yeah, go ahead. What's the practice like?
When I went back to Duke, I was heavily invested in peripheral vascular disease, venous reconstructions. Around 2008, because of changes in faculty, Tony Smith walked in and said, I want you to start taking care of vascular malformations. So started doing vascular malformations around that time, built a pretty successful practice at Duke. Matt Hawkins and Annie Gill had a really successful practice down at the Emory and the Children's Hospital there. But then coming back here, there was a real need. So here in my practice now, it's heavy with vascular malformations. I still do a lot of venous reconstructions. There really hasn't been a need for peripheral vascular disease. But I also moved in sort of the oncology space, doing renal, lung ablations, as well as bone MSK interventions, some pain, carrying Dave Prologos.
All right, carrying the mantle for sure.
A little bit of Prologo time when I was at Emory, so time not wasted. So brought some of those interventions with me here and have continued to do a lot of those things. So,
yeah, what about just like for the full gamut of just regular IR stuff, like biopsies, drainages, nephrostomy tubes, like all that stuff, still part of the practice, or?
We have 3 dedicated C-arm rooms. We have 2 biplane rooms that we share with neurointerventional that we get time in, especially when we're doing vertebral augmentation procedures where we like to use biplane. We do have a dedicated CT scanner, which is nice. It's actually manned by our techs and nurses.
That's great.
And so, we have been heavy with lung biopsies and soft tissue biopsies, targeted biopsies with CT. We do use ultrasound from time to time, but a lot of that's handled by the abdominal division. It's a wide-ranging practice. I think we're pretty well deployed across all the service lines that you'd like to be deployed in. The one we're not ideally deployed in is really peripheral vascular disease, but we do have an agreement or an arrangement with the VA at an outpatient center where we're doing peripheral vascular interventions on veterans.
Cool. Deserving population. So that's good work. All right. So covers kind of the history of how you got to Wake and what the practice looks like now. So the topic is going to be cone beam CT. Just for the uninitiated, do you just want to talk about like what, on a real basic level, what is cone beam CT? Like for someone who may have never seen it, or because we have medical students and trainees out there, but a large part of the audience here is going to understand what you're talking about.
The easiest way of thinking of it is, a fixed volume with a C-arm detector, X-ray detector circling the patient, and then acquiring a volumetric measure of what's in the field, and then using that. It's a little more cumbersome than you would have with a traditional CT scanner because there's a lot of potential moving parts that come into the space that you account for when you're moving somebody in and out of the CT scanner. The volume rendered offers you a lot of opportunities, whether you're trying to use it for angiography and you're delivering contrast into a volume to try and guide you into a direction for a treatment, or you're acquiring a volume much like you would with CT and trying to target therapy. And that's really the area that I've adopted it most. I'm not heavy in the liver oncology space. Well, I'm not really in the liver oncology space. My partners are. But I've used them actually as mentors to develop some of these alternative uses for cone beam.
So will you just kind of run us through which procedures that you're bringing in cone beam CT for?
It really started around using it for aortic endoleaks. So I've had a tendency at all the institutions I've been at as being an endoleak person. For the ones that have, failed 3 or 5 interventions, and then I'm the 6th sometimes.
Oh man, that's the best type of person to have in your practice.
Yeah. So, but it started with simple things, just using it to stick the sac. And then with the help of some industry support, we started using more fusion where we're taking the CTA, whether it's the arterial phase or the venous phase, and using it to actually understand the sac. So not only targeting the sac to optimize you to get to where the leak's coming from, it's actually marking where those vessels are coming in and out of the sac. So rather than just blindly roaming around the sac and looking at vertebral levels, we actually can put little fiduciary markers on actually where we think those vessels are coming in and out based upon the fusion CT that we're combining with our cone beam.
So in this situation, I'm just trying to wrap my mind around it. You have like the cross-sectional imaging that was obtained before the procedure, say it's the arterial phase, and this is where you see like, a suspicious vessel. And then you do your cone beam. I guess it would be a non-con with the patient on the table, right, of the sac. And then there's an overlay where you can fuse those 2 images, and then just like on the software portion, like on the workstation, you can say, this is where the vessel is, this is where I want to go, and it'll pinpoint that. And then like whenever you hit the regular fluoro pedal, you can see that location.
Yeah, we're looking at a fused image. That's a fluoro overlay with the markers that we've placed while looking at the scan that's fused with the volume. Sometimes it can be difficult to get those to co-register because your CT's acquired supine and the patients are laying prone. So sometimes it get more dicey when you're getting up into the thoracic or something that's high, but most of the time the lumbar is pretty reproducible. So, we're accessing the sac, looking at a trajectory planning type of software overlay. We're looking at a bullseye and a progress view. But then once we're in the sac, we're really trying to target those little, they almost look like buttons that we'll put where the lumbars are coming in that we've marked from the CTA. And those are actually displayed on the fluoro screen.
Super cool. So when you hit the fluoro, so you hit the pedal, you can see the entry points of those vessels into the sac. And if you change obliquities, like if you're like, hey, I need REO 30, LAO, whatever,
right,
it's gonna, that's okay, super nice.
Because the volume's registered to the patient, which is registered to the volume of the room. You can actually move the patient and then and it'll actually adjust. You can see it adjust everything as you're changing your obliquities and moving for centering and those types of purposes.
Oh, very nice. Is there also, like, say you're looking at the sac and you're like, oh, I think the best obliquity, like you're looking out of the Fusion software and you're like, I think it's going to be LAO 45, and you have that on the Fusion. Can you hit a button? It'll just take you to LAO 45, and then
if you can store that's more commonly used when you're using like a trajectory guidance for a bullseye and a progress view. And then what we'll do is, when we understand, you can also save table positions, what's sort of an ideal obliquity. You can save those and they can be imported in. You press the button on the device to actually move to those, and then we'll store those. Usually we'll store our home position for doing the cone beam at 1. And then, then we'll start working progressively through, are we working on the access portion of this, or are we working on trying to get to the vessel? And store them sequentially in the machine.
Okay. No doubt there's some time that it takes to run the cone beam and then maybe to set up the software. Ballpark, how long between like the patient's on the table, you do the cone beam to where you have all this set up, and then you're ready to start actually hitting the fluoro pedal to either start accessing the vessel, like when we can actually, so all the planning is done with the cone beam and selecting the access points. Like how long, just ballpark, how long would that take?
For just doing a simple trajectory guidance to get into the sac, or if I'm doing like a vascular malformation where I have a very good understanding of what we're doing, I would say it probably takes me 5 to 10 minutes at most. Okay. If we're doing something that's more advanced, where we're using fusion image, where we're trying to identify where these vessels are coming in and out of the sac. The other one, I actually really like using it. I like using it when we're doing renal transplants. Okay. So you know how you can have really complex like takeoffs, so you really understand where the vessel comes off. So what we'll do is put the catheter up into the common iliac, and we'll do a very low dose volume spin, one spin with a very low dose of contrast. And that spin gives us sort of the ideal projection of how we want to look at this, rather than sort of futzing around trying to figure out how to get that vessel looking the way you want to for doing the intervention.
So in this situation, catheter is in the common iliac artery. You're doing a bolus at the same time doing the spin, and then you have the 3D recon of the vessel and the takeoff, and you just kind of turn it on the software, and it's like, oh, LAO 26, cranial 12, and it can take you
ipsilateral common femoral artery access up. Get the catheter up. It can be an end hole catheter if you want to just use a Comfy or something, or you can put a side hole catheter up, and then just do something, it doesn't have to be anything, sort of like 3 for 15, something like that. And waiting for a 5-second fill, 5-second spin, couple seconds extra. And that usually will give you a very nice image to work off of for the rest of your case.
But just to go back to the procedure, so you got vascular malformations, endoleaks, renal transplants. How about prostate? We already said no on liver.
Yeah, well, it's no on liver because I'm not doing liver, but my partner.
Sure. People are doing it, just not Mike Miller.
Well, I just don't do liver. So Brian Corey, who's actually been my big mentor in this space, has and partnered with him, and Trevor Downing when he was here. They've sort of brought me along into the new age of cone beam and made me more of an adopter. I'm still a little bit old school with you put me in the arterial space, I just go back to dinosaur mode and some simple projections. It's just sort of how it is. But things where I find that there's an opportunity, I guess I'm starting to implement it more in my prostate practice, especially when I want to understand what I'm about to embolize. So we'll do a cone beam and make sure that we're not getting non-target filling of vessels before we do the actual embolization.
Okay. The only reason I brought the prostate artery up is because some people will use it to actually, they'll put it into the internal iliac, do a spin from that location if they're having trouble locating the prostatic artery, or sometimes the takeoffs can be a little bit fussy. And so it's nice to be able to lay that out. Even though it can still be hard to access it, at least you know that you have the projection right. But I also get it. So like you're talking about using it once your microcatheter is in the prostatic artery, you're just looking about, am I getting good prostate coverage? And is it not going anywhere besides prostate? All right. So nuts and bolts of just getting good cone beam CT imaging. So using it effectively. So I got a couple of things I want to talk about. Just setup, like room setup. I think anyone who's been to a new institution or worked with a lab that's not familiar with cone beam, but has like dealt with these struggles. And so I just want to talk about some things that you do for like either room setup or patient setup that make this a little bit more seamless.
Yeah. So because we're such a heavy user of cone beam, we actually have placed marks on the floor for resources. So especially with anesthesia, I'm very fortunate. It's my third institution working on anesthesia collaboration. And this is the best that I've been able to build at the 3 institutions I've been at. We actually have 2 anesthesia teams every day helping us with cases. We actually have a 7 a.m. in-room time, start time for on 3 of the 5 days with anesthesia. They're fully supported. Brian Corey actually came up with an idea of marking the floor originally to put them down and out of the way for most of the procedures that we did. But we actually found out with the room is ideally set for anesthesia to be at the head up above the C-arm. And then it's a matter of getting everybody up out of that way. So we've worked on the head position. I actually have anesthesia at the head position more than I have at the foot position because of vascular malformations I do and actually making sure anesthesia has access to the patient. We're pretty safe and pretty quick because we just really have a good understanding of where people need to be for a cone beam to be successful.
So as far as that anesthesia, let me go back to that. Do you have like there's physical markers on the floor where it's like, put your equipment here, like don't pass this line?
Yeah, it's actual like a striped yellow black line that sits on that's on the ground, especially for what's the foot position for anesthesia, which is on the left foot. It's across from you if you're standing on the right side of the table. And then the other ideal position, because of the way the C-arm articulates, is to the head and to the up and to the head to the right.
Okay, patient right.
Patient right.
Got it.
Which if you're doing like a TIPS, it's too many people up there. So we'll put them down if you want to do a TIPS and use cone beam for a TIPS. We'll put anesthesia down because it's just too heavily populated at the head of the bed if you have anesthesia up there. Yeah, exactly.
Right. The other thing I wanted to talk about is tubes and lines. So, like, what do you do with the tubes and lines? Are you unhooking each spin? Do you run them down the side of the patient?
When they're at the foot position, we'll run them along the side of the patient. When they're at the head position, co-band is your friend.
So what are you co-banding it to? Like,
while you're co-banding, you're sort of co-banding it in air and space, and then it's supported when it reaches outside of that C-arm. It's usually to an IV pole or something like that, or to the side of the anesthesia machine. We'll find someplace where you can support it at that point. But we'll put all the anesthesia, the gases, IV connections, A lines, we'll put them all into that sort of tube that's coming out, because that's the only place you can be at while the C-arm's articulating around is to that top right-hand position.
Top right-hand position. And whenever your cone beam does a spin, is it 360 or like how ballpark, do you know how many degrees? Is there a gap in there?
There's a gap. There is a gap. It's not a 360 degree acquisition.
Got it. So getting good imaging quality, I'll tell you in my experience, the biggest player has been respiratory motion as far as like getting a good picture. And so I think most people know that like breath holds, whether you're doing, well, I'll just leave it to you. Like, so how do you get a good picture? Like, what are the things that you're worried about?
Why do you build a really successful anesthesia relationship? So that breath holds are not a problem, right? So you can just I can go play my video game and we have control of the patient, and that's very helpful. So we don't do a lot of sedation. We do sedation cone beam procedures if we're doing like drains or simpler procedures. So we're trying to do something that just needs sort of an odd trajectory to get into something. And typically with them, I'll do breath hold out. You know, I always have taught that you spend 2/3 of your life not breathing, you don't spend 2/3 of your life with a full breath in. And so if you can get somebody to hyperventilate, they actually can be comfortable with the breath hold out. You just have to coach them because it's the opposite they thought of when they were trying to swim to the other end of the pool.
For sure. Good tip. So breath out, good breath holds. Then the other thing that I wanted to ask you about is when you're doing, like if it's something that is going to require a contrast injection, like maybe that renal that we talked about, do you cut the strength of the contrast so it doesn't streak out your picture, or?
We do. We'll use like 30% contrast for a lot of our things. That the key there is to remember to keep mixing your power injector.
Yeah.
So it doesn't, all 30% is sitting at the very bottom of your,
Sure.
as you've just been doing injection after injection. So those are kind of things to remember.
Okay. So 30% and 30% gives you I guess like the question about 30%, 70% saline is that so if you're just doing a traditional DSA, still looks okay? I mean, it's DSA.
Yeah, right. Yeah. It still looks good. I think we'll use 100% contrast just from simplicity of our techs. We have, a lot of tech transition and stuff like that, but where we think that it may have a greater impact, then we'll cut down the contrast, especially for things where you're trying to control contrast dose, like the renal transplant intervention.
Okay. I'm going to start asking about a procedure that I don't know as much about, but I want to kind of hear how you've been using cone beam CT to work through this stuff. Is the vascular malformation practice that you have, and how cone beam plays a role in that?
A few years back, I just, when you're doing head neck vascular malformations, it's just sitting there in front of you. The head's in the right positions, everybody's out of the way. So I started doing it for simple, macrocystic lymphatic malformations, see it fill, see it unfill. And you start using it for microcystic lymphatic malformations and seeing the spread of the agent and those sorts of things. And the things that I started realizing is agents you can't see, you could start seeing. And what I mean by that is when you're using bleomycin with albumin and air, you can see that on a DSA, but do you really see the volume of your sclerosant? And so when you start, if you're using a displacement method, so you get into a malformation, you inject contrast, now you displace it with the air or the foam. At that point, you get that kind of an appearance. But when you start doing cone beam CT, you start having a much better understanding of your volumetric distribution of your sclerosant. And that's not just like sotradecol mixed with lopiodol. That includes using bleomycin mixed with albumin and air. And where I found that it really made a huge difference in changing my understanding is when you're doing lymphatic malformations, everything stays kind of stagnant. So you can see the air displace. But when you're treating a venous malformation, you can get clearance of that air foam. And so what I started doing was I started having this better understanding of the use of bleomycin for venous malformations, like for, say, the tongue or the floor of the mouth. What I started doing is rather than delivering the bleomycin all at once, I started administering it over half an hour, 45 minutes to an hour, waiting for fixed displacement so I would actually see that the air column filling that malformation would stay. So early injections, because you're not getting a lot of sclerotherapy or thrombosis early,
sure,
it washes out. But by later in that case, if you take your time with the bleomycin, you actually start seeing it fill the venous malformation in the distribution that matches the volume. And it's really helped me understand. And I think it's also helped me have better outcomes when I'm using it that way.
So give me an example. So as you're injecting your sclerosant, do you do a couple spins periodically through the process? And then what point do you do the spin? Do you do a pre and a post, or a pre and when you think there's a post? Or
yeah, so we'll walk through a tongue, right? I'm not ultrasounding the tongue to stick the tongue. I basically I'm literally just I'm being a dentist. Yep. I'm opening the mouth and I'm sticking a 25 gauge needle in the tongue.
Got it.
And then start injecting. And I'll do a DSA run. And then I'll do a cone beam with that first initial contrast injection.
Okay.
And then I'll mix up my bleomycin foam sclerosant. Usually it's about 15 units and about 15 cc's when you're total, which is perfect math for my brainstem.
Yes.
And then so I'll inject the initial 3 cc's and we'll do a cone beam. It's not timed. It's just injecting everybody out of the room. Let's do this. And then I'll serially do those cone beams until I'm happy with the distribution of the foam sclerosant within whatever I'm targeting, whether it's tongue, flora, mouth, and then just serially keep taking images till I'm really out of foam sclerosant.
Okay. And then a final, I would imagine.
A final,
Yeah,
yeah.
of course.
And then we can overlay those. And usually on another unit, I have the MR. And there's actually an article that I was sort of trying to get ready for this, published by Wallace and JVIR back in 2008, where Gil Soule talks about using it for vascular malformations. He has a beautiful image of a microcystic lymphatic malformation in the cheek, where you get to see his sclerosant beautifully distributed and almost perfectly matches with the MRI. And I think it's that understanding that's helping me be more effective in the vascular malformation space. And that's not including some of the things in targeting, like things that are difficult to target.
Sure. It's funny, like the things that you don't see, you just don't know about. And then once you see them, you realize like you've been missing some things, or it's just a different world that kind of opens up. I was curious if you've used the trajectory guidance stuff. Have you ever used it for things like this where, like you mentioned, like having to stick the sac or whatever, maybe you have a deep lymphatic malformation where you're trying to target a particular area?
I have a favorite case, and we actually presented at ISSVA a couple years ago where there's this guy that came in with a pelvic AVM, just found on a trauma, just had a trauma, find us pelvic AVM. So I get a hold of him, pretty complex arterial and venous contributions and outflows to the malformation, but there was a sac aneurysm associated with a nidus. So we did arterial embolizations, a little bit of combination of venous embolization combined as a first stage just to slow it down. Then I brought him back, did another pelvic arteriogram, but this time watched the late venous phase. And there was a vein that came out, was just over top of the pubic ramus, that we were actually able to do a cone beam trajectory, lay that out, and then stick it with the cone beam CT overlying the fluoro. We were able to stick the model and get directly into that vein that was coming at me over top of the pubic ramus and drive ourselves right back to the venous aneurysm. And from there, I was able to coil embolize the venous aneurysm and pressure sclerosant back into the nidus. It was a fantastic case. Wayne Yates was asking me why I was using cone beam for this. And I was like, because I can.
Yeah.
Because I could see all this stuff rather than, I understand what he's saying. You do a whole bunch of runs.
And you try to do the same thing in your head.
Yeah,
like
and
stick
it.
The mental gymnastics of, and not to say that doesn't work, but this is a different way. This is just a different way.
And that is truly, I've had a couple cases where we're able to target things, but that's one of my favorite cases because it took something that was going to be difficult to do and made it very easy to do.
The way you did this case, did the trajectory software basically say, stick this place on the skin, drive your needle to this place, and there's a little X or something on the screen? Like, just how does it look to you?
So when you use the trajectory guiding software, you're able to use multiple obliquities on that. And what you do is you sort of choose your multiple obliquities, and then you lay your cursor on the thing you're going to target typically. And then what I'll do is, if I'm liking how things are looking, what I'll do is I'll roll that cursor out to the skin level and drop it. And usually it's in an obliquity that misses things, like for this, the bone. We actually access the posterior division of the internal iliac, making it into an internal iliac artery aneurysm. And our target was a calcification that was on the wall of the posterior division. And we used that to actually target coming in and accessing the posterior division of the internal iliac artery. So there's different ways of targeting. In the vascular malformation, it was in combination of the venous phase of the arteriogram on cone beam. And then on the accessing the posterior division of the internal iliac, it was actually using the intrinsic calcifications of the artery that we targeted.
Cool. Very slick. The other question I wanted to ask you is, like, away from trajectory guidance, but you'd mentioned it earlier with the endoleak cases that you can do the fusion, basically the fusion overlay of a prior cross-sectional imaging. Do you have to acquire those images, like, specifically? Or what I'm wondering is, do you have to do something on the front end to make those images ready for fusion, or can it be any CT from outside institution X?
Yeah, it's just a matter of matching up the volume. Now, when I was at SIR, I sat down with industry reps and they tried to walk me through actual fusing the two, and it's an art to do it. It takes a while to figure that out, but a lot of times, like for an endoleak, what you do is you try to align the endograft, and if you can align the endograft, everything else sort of comes along with it.
So the other question I had is that, like, this is just very practical. Like, you had to learn this on the job. You had some partners who helped you with it. Can you envision a situation if you didn't have your partners who were there to help you, but you're still just as motivated to do it? Did industry play any role in kind of either coaching you or your partners up? Like, did they send any extra assistance? Like, are there any good questions to ask? Like, sometimes, like when you're in private practice, you feel like you're on an island, and sometimes industry's like your partner in terms of like getting you and staff up to snuff on these kind of things.
I've always been a heavy industry partner. That's really who's helped me. We actually have a posting sheet for all of our cases, and one of the factors actually in the posting sheet is who do you want in the room with you. And I have somebody who's very effective at doing the fusion, especially when we're doing vascular malformations and trying to get like an MR fused with the cone beam, which actually has become easier because there's like a one stick fusion thing there's like a one-click fusion technology that you can do for head, like the skull, because it's the skull. You just click, says skull, done, right? But you can't do that for the aorta when you've got supine and prone. Those are things that, we've kind of learned, but that individual's made me very effective, especially when I'm using it for these boutique interventions.
No doubt. So the other thing I wanted to talk about, and it's a little bit of a left turn, but I just did want to cover it, is contrast bolus timing, and how, like, maybe however you want to talk about it, like whatever case like exemplifies it the best. But if you can give our audience some like real-time examples of what your contrast bolus is and what your timing is on the spin, so that you either get pictures of the whatever, the target organ, or you get good pictures of the arteries, or get good pictures of both. I'm just curious how you did that.
Well, this comes from my partner, Brian Corey, who does the liver. And basically there's a couple different ways to do it. What he'll do is he'll drop into the hepatic, common hepatic, and he'll do a run like 2.5 for 12. Okay. And that he then really assesses what the fill of the tumor looks like. Is there too much reflux? Then he'll drop down his rate. Mm-hmm. If there's not enough, then he'll increase his rate. The math comes down to about 5 seconds to fill the hepatic artery.
Okay.
5 seconds to complete the spin at 40 degrees per second. And then he adds 2 seconds as a buffer.
The wiggle room.
Yeah. Wiggle room. And that's his protocol for what he injects and how he programs to acquire the spin. If you're down, you're going to do like a prostate and you're going to be in the internal iliac, I don't think you need to be at that high of a rate. So you could, sit there maybe 3 cc's or something like that in the hypogastric and make an assessment. You'll get, I think, good fill with using that same model, the 552. You'll get a good acquisition and understand your vascular anatomy if you're using for like a prostate.
Okay. So basically, just to recap, rate 2.5, and that's based off the just the angio, the conventional angio. You can drop it down, you can raise it, do whatever you need to do to stop reflux, and then basically once you have your rate, you want about 12 seconds total, and then so you just back into the math about how long you'll do your injection. So if you're 2 cc's per second, then you've done 24, right?
Right, and you're not talking a lot of contrast with another
so additional 30% contrast mix. So okay, very nice. Is there any ever reason to do? I know some software has it where you can have high quality images or like a faster spin. That's usually the trade-off. You either get a faster spin with lower quality images or the slower spin with the high quality images.
What that just does is comes down to time. And so more time is more opportunity. More time is more opportunity for motion artifact. So
Agreed.
Typically 40 degree per second is 5 seconds. 28 degrees is going to be 7 seconds. 16 degrees is going to be out 13 seconds. So if I'm doing like an MSK intervention, I did a pelvic met. And so I did a very slow spin for my initial acquisition that we were going to fuse with a PET.
Okay.
So that it made for a very detailed map, and then everything drops down to the faster spins.
Okay. So the trade-off is faster spin, crummier images, but at the same time, less motion artifact, right?
That's correct.
And so for yours, if you're doing something where it's not prone to motion artifact, probably a good example is prostate, bone,
Right.
anything that's stationary, then you can kind of reduce the speed of the spin, get a nice high quality image. And then after that, you're just like, maybe it's a little bit more of a workhorse where you just do the 5-second spin pretty quickly.
But if you're doing something like cryoablation, right, where you're actually the tissue, when you're trying to get an improved visualization of soft tissue differences, you actually need that higher intensity image. So that's where, like, if you're doing a cryoablation, you may not see it as well on your faster spins, where if you do a slower spin, you'll actually get to see the subtle difference between your ice ball and the surrounding soft tissue.
Okay. At least what I tell people is, there's not like a right way and a wrong way. It's just, what are you trying to visualize? How much so your main contenders are your motion and like your soft tissue differentiation, and you just have to kind of balance those. I guess in the kidney, you would have to do a longer breath hold, but if you have anesthesia on board or your patient's like compliant, then you're all good.
Anesthesia is good. I know there's
That's a good takeaway.
There's part of it's where you're in between anesthesia cases. Anesthesia may not be seen that good, but once you're in the room working with anesthesia, it gets a lot better.
I'll just throw this out there, my 2 cents. I'm in a private practice, and resources can be, not always, but can be scarce, and especially anesthesia time. But our anesthesia teams are very accommodating, especially when they know about it ahead of time. So any of my outpatients where I think that I'm going to need them, it's just easy to have them on board. Like, that's something they can work into the schedule. What is tough is like, you have an emergent procedure where you got to do something in the next 2 hours. But I just try and imagine that if someone asks me to do something, like drop everything and come do a case, like sometimes that's a bit of a bear depending on how your day is going. So
the other win you can get with anesthesia is stacking. So one of the big wins we had was they were coming in at 6:30. So we tried to be there so we could have everybody consented and get the patient in the room by 7, because they were sitting around just drinking coffee and not doing anything if we wanted to do an 8 o'clock case. So by us moving earlier, we also were able to move up their stop. Our kind of relative stop is 3:30 for anesthesia. So we really try to get packaged into that. And everybody complains, well, why should they go home at 3:30 and we don't? Well, let's just get the stuff done based upon what anesthesia does. We still go past 3:30, but we try to get our elective cases hammered out before then.
Nice tips to work with anesthesia. Any other resources or research that you found helpful in, like when you were either getting up to snuff or preparing for the podcast, that you found helpful that's good for trainees or people who are just, trying to learn more about cone beam?
That Wallace article from 2008 in JVIR it's actually a nice general article looking at the different indications and utilization of cone beam. It is actually wide ranging from oncology, peripheral vascular disease. They actually spun a thigh, which I would have never thought to do that. But it's a pretty wide-ranging article, and I thought that was nice to review. We're actually looking at our vascular malformation experience and have submitted an abstract for SIR this year. Hopefully it'll make it through the gauntlet and be able to be presented. And actually we're finding that there's been an impact on outcomes when we're using cone beam as opposed to not using cone beam for our vascular malformations. And it's wide ranging from venous, lymphatic, head, neck, body, pelvis, AVMs. So it's a pretty wide ranging subset of vascular malformations. Currently, I have over 300 patients in my vascular malformation practice here. And that's been a 5-year build of the 6 years that I've been here. And we've actually established some nice working relationships with some other institutions that are within the ACC distribution and are doing vascular malformations in collaboration with their vascular malformation teams. And that's actually been a lot of fun.
So one of the other things I wanted to ask you about, and I saved it for the end, advice for someone who's maybe getting a new Angio suite and they're going to get cone beam CT. Any advice on things to like ask for or recommend as far as like what you want out of hardware or software? Or is that just kind of a question that, you just came into an institution, you have what you have?
Kind of have what I have.
Sure.
If I could evoke my inner Brian Corey and all the stuff he asked for, but he's been heavily engaged with the company that we use as a consultant in development of a lot of their software and trajectory and cone beam and the road mapping software and stuff like that. So he's been heavily embedded. So we're at a real advantage here with the company that we're partnered with. But if you can, while you're trying to make these decisions, I would not skimp on software from a standpoint, because that's where a lot of the companies will get you, is like, you don't think, well, I'll save a few grand here in what this package or that package is. And then you're wondering why you're sort of stuck in the mud, not being able to do certain things. And that software is really critical to your success, because that's really what you're asking for, is to take the image that you've acquired in that volume and now fuse it with the fluoroscopy that you're using to get to where you want to get to.
I'll just throw in one thing, only because I went through 2 institutions that did purchase some equipment. I didn't have a lot of say in it, but we got what we got. And I will just say, if you have any say in the size of the image intensifier, so the thing we call the II all the time, bigger is better. As far as I know, there's no downside as far as your cone beam CT and getting a smaller one. Bigger is better. Like, we have a smaller II in one of the places that I work, and it's a little bit painful. I mean, not that you can't get it done, but
Neuro room is not your friend.
yes, exactly. Yes.
Yeah, I know that's what you're saying.
Yes.
Neuro room is not your friend. And so, yeah, bigger image intensifier, and pay attention to bore size, because the bore size actually has a huge impact on what you can actually do. If your bore is small, you can't get into a complicated angle because you start touching the patient.
That's right.
Or hitting the table. So you want to have a large bore, a large detector type of platform. So you have a lot of opportunity to get things that you want to intervene on within your volume.
Yeah. And also super smart about what you said about the software. Like, it's amazing. The software just does make a lot of difference. And for some reason, like, having a lot of bells and whistles for me, because I've dealt with 2 different companies and 2 different software packages, it makes a big difference in part of like the user interface and like the user friendliness of the software. One of the other things I'll echo is that, like, you know, I'm with you in terms of like partnering up with industry. It's their equipment, it's their software. They're in a good position to educate you. And as soon as, like, if you're ever buying a machine, that's when you have like the most attention about education. So go with it.
You got to get in there and get using it. And then you got to consistently use it, because if you don't use it, you lose it.
Yes.
And if you train your techs to do it, you'll lose it again. We sent a couple technologists even to very nice destinations for training.
Like
very
Hawaii.
nice. And no, even better. And they're gone. And now, fortunately, I have a super user in my partner that I pick his brain every day whenever I'm using the technology. But you really have to get in and use it, get dirty with it, and then keep using it. And even if you're talking about whether you're in a training program, you know, actually, I will leech off of my trainees. They'll come into the room with me and they make me better in that room, because they've done so many liver cases with Brian that it's like, here, come with me. I'm going to do something. Help me get through this. So they're doing a fantastic job. Our trainees are very adept with managing cone beam volumes and really getting the most out of these units. And that's really the key. So.
And actually, you touched on another thing that I'll just throw it out to the audience also, as far as like getting the reps in. There's plenty of cases that I do, like when I think of prostates, where it's not mission critical that the cone beam CT is operational. Like, I feel good about where I'm at, like I'm in the vessel, feel good about coverage based on my Angio. But, you know, I'm like, let's just do the spin. We always do the spin because it's just one more rep that we can get in, and like it makes everyone more comfortable with the whole process. And for some reason, we just went through that period with our technologists where some doctors were using it, some doctors weren't, and for similar cases, and they were a source of friction. And so just getting them the reps and getting them comfortable with it helped kind of lower that friction to where, like, whenever I said cone beam, I didn't have to hear that collective sigh, like, oh, we got to do a cone beam.
Yeah.
Like, come on.
That's real.
Oh, no doubt. No doubt.
Again, we can take a lot, we can help them with that, because in my environment, I don't find that we're investing as much as we should in our technologists' education around cone beam and using the software. So when I go into the room, I really lean heavily on I actually teach the techs as I'm in the room on how to use the cone beam, because that's going to pay me back at some point.
No doubt.
So, or somebody back. So
right, maybe
yeah,
actually you, but maybe
could be one of my
yeah.
could be a
Right.
partners, right? It doesn't know how to use the room because they're new to the practice. They haven't used the equipment that we have, and they walk into the room going, I don't know. So they were comfortable using it with another company.
Of course. Mike, anything else? Did we leave any stone left unturned here? I mean, I think we covered it.
Thanks for the opportunity. You know, I was little worked up about this whole thing about how I would do and everything.
Crushed it, man.
But yeah, well, thanks. I've been really happy with it, with being a late adopter. I was a late adopter of renal cryoablation just out of necessity because there's nobody left here to do them. So here you go. And then next thing you know, I'm doing lung ablations. I'm like, okay, here you go. And that's kind of the fun of being an interventional radiologist, is remaking yourself in your 50s. And here's another technology. Who knows what's going to come up next in 10 years from now and what else I'm kind of doing. But reshaping yourself in interventional radiology is actually one of the best things about the specialty.
I mean, when you think about just to piggyback on that, like the breadth of interventional radiology, it's so vast. And like whenever I think about your practice, like you went from peripheral arterial disease to venous malformations and, became the endoleak guy. And then you also to like layer on like ablations, like lung and renal on top of that. I mean, those aren't necessarily skills that are like, I mean, there's definitely overlap, but like, I mean, come on, like peripheral arterial disease versus like a renal ablation, like you're talking about like the night and day. So yeah, the practice is cool. I think you have a lot of people who are nodding their heads right now that interventional radiology is cool. And to me, it's up and to the right for this specialty. So
yeah, well, it all comes down to fundamentals, and you have fundamentals to scale. And my fundamentals were put into me in my training program. And so have I been able to scale that out, whether it was doing aortic endografts, tips, complex venous reconstructions, critical limb ischemia? It really comes down to fundamentals. And if you have sound fundamentals, you can scale out to just about anything in this space, which is awesome. Now, we don't have to go into the lane problem. Like I have a lane problem. Like, so there's so many things I'd love to do. I have a lane problem where vascular surgeons and other specialists don't have lane problems because nobody's calling them for an abscess or any of that all the other commodities that come with the specialty. But it's a risk reward that comes with the specialty. But it's been a great ride.
That's awesome. Well, if no one from BackTable has told you, thank you very much for coming on. Even though you thanked us, I mean, the reality is like you're here giving us your time and doing this for us. So we really appreciate it. Mike, thanks for coming on the show.
Thanks, Chris. Appreciate it.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Dawn,
Michael Barraza,
and Allie Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang,
Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Jamila Kennebrew
and Judy Dela Cruz.
Thanks again for listening.